Hello, friends. Good evening. As promised, today we have a guest lecture by Dr. Meghna A. Nayak. She's a specialty fertility doctor at BPAS, London, UK, and course director MRCOG Part 3 courses at Study MRCOG. Before that, she was a student both undergraduate and postgraduate at Kasturba Medical College, Manipal, where she got the best outgoing MS candidate, as well as Dr. A. Padma Rao Best Resident Award. She also got gold medal in OBGYN, and she was the second highest in MBBS, with distinction in all years. After that, she did fellowship in reproductive medicine under Rajiv Gandhi University of Health Sciences, Bangalore, at Manipal Fertility, Bangalore. She had an illustrious career and she has won many awards for Best Paper, Best Poster, and ICMR Award, as well as Sri Ratan Tata Scholarship Award. I am proud of her, not because she is my daughter, but while I was teaching her, I realized that she actually is better than me, and she's almost like my teacher and guru. And she's a very popular teacher in Study MRCOG group also. So I thought all of you should be benefited by her teaching. So today she has chosen a topic which is very, very important for every couple and every parents who want to become parents. So she has piled up or compiled so many problems, A to Z, and in each there are many, and she has a very interesting way of presenting that. So I don't want to stand between you and her. I will straight away make her the host and she will start thereafter. So please give me a couple of moments before I make her the host. Yes.
Thank you, everybody, for joining, and thank you for the lovely introduction. So today's topic is pathways to parenthood. So this has been a debate from time immemorial, whether parenthood is a human right. Those in favor have said yes, parenthood should be regarded as a human right. Naysayers have disagreed and said parenthood should not be regarded as a right. There has been thorough discussion about human right of homosexual couples as recent as 2020 with regards to right to parenthood. There's also the other side of the coin, which is the right of parents to decide when they would like to embark upon the journey of parenthood, and that is to do with legality around abortion. This has been a conversation right from the Egyptian era and civilization to 1920s when Mary Stopes in the UK worked towards women's right to have safe abortions if they wanted. This led to, in 1968, the legality around abortions in the United Kingdom. Soon after, in 1971, was the MTP Act in India. But you may have all seen in September 2021, as recent as a few months ago, the uproar around the Texas abortion law and how it is such a restrictive state even to this day and age. So Planned Parenthood is one such organization which is working towards health without borders in providing safe parenthood options to individuals in the United States. To rest this case, the Human Rights Declaration by United Nations states in its Article 16 that this right to found a family is considered to be such importance that it is recognized as a basic human right. So that is the end of the debate. Yes, parenthood is a basic human right, regardless of the gender, sex, sexuality, race, religion, and region of a person. I'm going to be using these terms quite frequently in my talk today, so I would like to start with the glossary of these terms. What is gender? It is nothing but the gender identity or the inner feeling a person has about their sexual identity. When it matches that of their biological sex, they are referred to as cisgender. But when they don't feel that they are of the biological sex they're born with, then they can have gender dysphoria. This is not a mental health condition, and we as medical professionals should be able to help these individuals, because at the end of the day, when they feel trapped in the body they're born with, it is our responsibility to help and ease them from that discomfort. So what is biological sex then? It's nothing but the 4Gs: the genetics, the genitals, the gonads, and the gametes. So the genes, when it's XX, the individual is a woman; XY, the individual is a man. This cannot be changed. And this is what determines the genitals and the gonads they're born with. The genitals cannot be changed, but they can be modified by cross-sex hormones and gender-confirming surgeries. The gonads and the gametes they produce cannot be changed, but because of the advances in assisted reproductive technology, we are able to provide reproductive choices to all individuals. Finally, sexuality. This is the sexual orientation or inclination of a person. When they are attracted to those of the same gender, it's homosexual, and those of opposite gender, it is heterosexual. But as I stated earlier, parenthood is a human right, so all individuals, regardless of their gender identity, their biological sex, or sexuality, deserve reproductive choices. So that's something that I will tackle amongst others today. As obstetricians, we all share a common goal across nations, and that is to have a healthy mother, a healthy baby. As fertility experts, we are no different. In fact, we're the chip of the same old block, and our journey towards a healthy mother and a healthy baby starts even before a pregnancy, and that is to optimize the health of a lady before she embarks upon this journey. So a lady who wants to have a pregnancy should have a pre-existing health set, which is optimized. She should be on the right dose of folic acid. She should have her cervical screening up to date and normal. We have to ensure that the medications that she's on have minimal or no teratogenic effects. We have to provide her information about her lifestyle choices and give her an opportunity to change those before she embarks upon a pregnancy journey. Give her the options of contraception to avoid an unplanned pregnancy or to space out a pregnancy, or use it as a makeshift until we can optimize her health for a pregnancy. Vaccines, of course, nowadays, COVID vaccine, and then rubella and other vaccination, we need to be sure that she's up to date with those and her health is optimized in terms of her weight as well, because starting a pregnancy with a high weight can push her towards a high-risk pregnancy. So these are some things that we as fertility experts need to think about before offering fertility options. Now, going into the conditions and offering fertility choices, I'm going to tackle A to Z, as my father already said. So the first condition that I'm going to talk about is androgen insensitivity syndrome. So A for AIS. I'm sure you've all listened to my father talking about the disorders of sexual development. So just to recapitulate, androgen insensitivity is when an individual is born with a karyotype XY, which means it is a male karyotype, so they do not have a uterus. But because the androgen receptors do not respond to androgen, there is disorder in the development of the genitals and the gonads. The gonads are dysgenetic, which means they don't have a functional ovary or testes, which cannot produce gametes. So this is the challenge we are faced with when it's androgen insensitivity. No uterus, no ovaries or testes, no gametes. So the options, if there's no uterus, then the answer is surrogacy. There's no gametes, means gamete donor. So the type of surrogates can be of two types. One is a full or direct surrogate, when the same person is the egg donor as well as carries the pregnancy. This can be possible by either doing IUI or IVF. A gestational surrogate is one who only carries the pregnancy or the embryos, which means that the egg is donated by another individual. And this is possible only through IVF. Now, going slightly further into this, if the person who has androgen insensitivity is a woman or decides to continue to be a woman, that is the gender she's born with and wants to continue to be in that gender, then the options are, as I said earlier, direct or full surrogate, but the IUI or IVF can be done using the partner's sperm in a heterosexual relationship, or a donor egg and a separate gestational surrogate, again IVF, using the sperm of her heterosexual partner. But if the person is a lesbian or in a same-sex relationship, then the partner can be the one to carry the pregnancy and can have donor IUI or IVF. If the person with androgen insensitivity wants to continue the role as a man, then the partner in a heterosexual relationship can carry a pregnancy either through IUI or IVF with the donor sperm, or if the man is in a homosexual relationship or is gay, then a surrogate can carry the pregnancy through IUI or IVF using a partner sperm. So this is the first issue in androgen insensitivity, and that's tackled. The second issue is, this is a condition which is X-linked recessive, which means the mother is usually the carrier. If a couple has one child with androgen insensitivity and they do not want the next child to have the same condition, we have the option of offering them IVF and doing a pre-implantation genetic diagnosis. If we miss the bus, the next choice is to do a prenatal diagnosis. Issue number 3 is, as I said, it's not about just getting a person pregnant, but it is also to ensure that that person is healthy to carry that pregnancy or healthy to look after the child that they have. So we need to know that these people can have gonads at risk of cancer. So we need to think about gonadectomy post-puberty, and finally HRT till they reach the age of menopause to ensure they have a healthy heart, healthy bones, and have a healthy life. So that's A, tackled. Next is B. So B for bilateral tubal block. Now, in the day and age of IVF, does recanalization still have a role? Now, this depends upon the age, ovarian reserve, type and cause of the block, so whether it's distal or proximal, or the cause, whether it's post-infectious or post-surgical, other fertility factors if they are involved, affordability, expertise available to carry out the procedure, and finally, it's an informed choice to be made by the couple. This was the first indication for IVF, which was tubal block, but now we have extended this to other fields as well. So in a lady who is young, who has a good ovarian reserve, and usually a post-surgical bilateral tubal block with no other factors contributing to infertility, recanalization can be a good option. The positive is that 50% of the time it is successful, and a natural chance at pregnancy at the end of 1 year, the cumulative pregnancy rate is better than that with one cycle of IVF. The negatives, of course, to every positive, and looking at it as glass half full is 50% failure rate. So not all recanalization will end up in anatomical correction of the defect. There's always a chance of ectopic pregnancy in that tube. And if there's no pregnancy at the end of 1 year, then we are still left with the option of IVF. And in those who are older, who have a low ovarian reserve, other factors that are contributing to IVF, to infertility where IVF may still be required, or post-infection bilateral tubal block, then think about IVF directly, because it's not just about the anatomical correction and anatomical patency of the tube, but also the functionality of the tube. And usually post-infectious tubes may not have the same function. And even if you think about anatomically correcting it, they can still have problems like hydrosalpinx, and that can even reduce the success rates with an IVF. So think about IVF in those instances. Now, women are not the only ones with the tubes. Men have seminal tracts as well, and obstructive isospermia can be a problem too. Chances are still the same. The choices are still the same: recanalization or surgical sperm retrieval, just as with women. And of course, once they are surgically retrieved, ICSI becomes the option of choice. So how do you decide again with obstructive isospermia? Same as with women, depends on the cause. Post-vasectomy, you can think about reversal, but bear in mind that if there's a long gap between vasectomy and recanalization, there could be anti-sperm antibodies, which can reduce the sperm production as well. Post-infection, again, it's not just about anatomical patency as with women, but also the functionality. So post-infection, you may be better off doing a surgical sperm retrieval than trying to recanalize. In congenital absence of bilateral vas deferens, which I will be talking about more in detail, think about doing cystic fibrosis testing, because most individuals with CABVD might be carriers of the cystic fibrosis gene. And surgical blockade due to surgeries like inguinal hernia operation, and that could be one of the causes, and you can think about surgical correction in those individuals. Next, C for chromosomal abnormalities. Now, how do you diagnose? First, look at the hormone profile. In hormone profile, you will see WHO type 3, which is hypergonadotropic hypogonadism, which means that the gonads are at fault and the FSH and LH will be higher than 40 on 2 instances, and that would be the hormone profile to expect. Look at the karyotype. Various conditions in men, like Klinefelter's, in women, like Turner's, which I will be talking about, could be one of the causes for the abnormalities in the fertility. Y chromosome microdeletion is one of the conditions in men that can contribute to azoospermia, and we will talk about that again in detail. So the treatment options, they could still have natural conception, albeit the chances are very low. And this is more so if they have mosaicism rather than a complete chromosomal abnormality. Other option is to do an IVF. Now, IVF is possible if we are able to retrieve the gametes from them. If not, then we have to think about third-party artificial reproductive techniques. If these are conditions which have inheritance, then think about doing pre-implantation genetic diagnosis as well. And finally, if we missed the bus, as I said earlier, prenatal diagnosis needs to be offered. Next condition is Downs, so D for Downs. This is quite controversial even now. As I said, all individuals should have the right to parenthood. And in this day and age, when we have advances in medicine, the life expectancy has improved drastically for those with Down syndrome to 55 years. And not all individuals with Down syndrome have mental retardation, and some of them have variable cognitive functions and are still able to have an independent life. Gone are the days when individuals with mental capacity or lack of mental capacity were offered sterilization. It's against the human rights now to do that. So they still can get pregnant, and it depends upon the medical status as well, because these individuals, 50% of them can have cardiac diseases, they can have other serious illnesses, and Alzheimer's, which can set in quite early. So though they have the right to become parents, we have to also think about the welfare of the child that they are going to rear. These children, whether they can fare well when they have a parent who has cognitive dysfunction and can potentially have life-threatening health conditions, is the question here still. And as far as fertility treatment itself is concerned, they can have inherent fertility issues, males more than females. In females, there is early menopause, or there is also lower quality of the oocytes when it comes to Down syndrome. And there's always a 50% risk of inheritance to the offsprings. So I can still say that this is a controversial field, that is fertility in individuals with Down syndrome. The next issue is those couples who have previous children with Down syndrome. There is an age-wise impact on the recurrence. It is 1 in 100, the recurrence rate. This is not very significant when the lady is already 40 years of age, because her inherent risk at that stage would be 1 in 100. But a lady who is 25 has a risk of 1 in 1200 of developing a child with Down syndrome. And when you look at the recurrence rate, that becomes 1 in 100, which is significant. So this is one field where we can think about doing prenatal diagnosis. If translocation-related Down syndrome is recognized, then you would offer them third-party ART if the translocation is translocation 2121, because the recurrence rate there is 100%, okay? So this is one of the conditions that still is quite controversial. Next is endometriosis. Why does endometriosis cause subfertility? There are various reasons why. There could be tubal block, there could be ovarian insufficiency, either due to repeated surgeries on the ovaries and loss of ovarian reserve, or it is, at the end of the day, an inflammatory condition which can impact not only the quantity, but also the quality of the oocytes. And finally, 30% of the cases, it's just that dyspareunia might be the reason why they are not able to attempt a pregnancy in the first place. According to the recent Feb 2022 guidelines on ISHRE endometriosis, it recommends that stage 1 and 2 operative laparoscopy before any fertility treatment improves the ongoing pregnancy rate. The decision to operate will depend upon the clinical features. So if it's an asymptomatic lady, you would not think about doing a surgery. And post-surgery, the decision to offer either ART or wait for natural conception depends upon endometriosis fertility index, which takes into consideration the stage, the clinical features, and the findings of the surgery. What is not recommended when it comes to fertility is ovarian suppression for long duration, and that does not improve the fertility. Postoperative hormones, which are usually treatment options in those women who have pain-predominant symptoms, is not to be offered in fertility because they are counterproductive, and most of the medications or hormones that are given have contraceptive effects and are not to be offered if the lady is desirous of fertility. Pentoxifylline, anti-inflammatories, and letrozole outside of ovulation induction is not to be offered for fertility purposes. When do you offer medically assisted reproduction in those with endometriosis? If it is stage 1 and 2, you would think about stimulated cycles of IUI, and this has higher pregnancy rate. In those with stage 3 and 4, if the tubes are patent, you would think about offering IUI. If not, you would do artificial reproductive techniques, again, depending upon the EFI or the endometriosis fertility index. There is no increase in recurrence rate, even if you offer ART, although with ART, there is a rise in estrogen, which is the culprit in endometriosis. There is no increase in recurrence rates. You would offer antibiotic prophylaxis in those who have endometriosis at the time of egg collection. And finally, it says that cystectomy is to be done only if there is an access problem or if the lady has pain also as one of her symptoms. But usual or routine cystectomy before ART is not required because that can reduce the ovarian reserve. So that's under not recommended. And what is of limited use right now, limited evidence right now, is pre-treatment with COCs or progesterone to increase pregnancy rate is not shown to have any benefit, and it might be just used for scheduling purposes. And non-medical treatments or complementary medication, still the jury's out on those. Finally, fertility preservation. The recommendation is to discuss with the women the pros and cons, but there's still no true benefits or evidence of true benefits as of now. Next is endometrial atypia. So again, E for endometrial atypia. In those women who are desirous of fertility, if they have endometrial atypia, the treatment of choice would then be to use high dose of progesterone to reverse that, so that the uterus can be preserved, and one normal sample of endometrial sampling before any fertility treatment has to be in place. And surgery is usually offered after a pregnancy so that there is no progression to cancer. Next is fragile X syndrome. Now, this is the most common cause leading to autism in these days, and it's also a cause of premature ovarian insufficiency. This is a condition where there is naturally a low pregnancy rate because they have hypergonadotropic hypogonadism. These individuals also require health optimization before they carry on to a pregnancy because they can have other impacts of low estrogen in the body. Usually the treatment is through donor egg. As I said, they have low ovarian reserve. And this is an X-linked dominant condition, so you would think about doing a prenatal diagnosis. However, prenatal diagnosis in this condition is quite difficult. I just have realized that I have up to Z conditions to go to, and I'm still at F, and we have a few more minutes left. So I will be continuing this on Sunday as well. The other option in such individuals is to offer them egg freezing or embryo freezing. And finally, offering prenatal diagnosis is the last option that we are left with. In gay couple, where it's men in a relationship with men, the options are, what is the problem here? There's no uterus. Okay, so then we need to have a surrogate who can carry the pregnancy. And the surrogate may be a direct surrogate, as I said earlier, who is the same person who is offering the eggs as well as the uterus to carry the pregnancy. So the option is either to do an IUI or IVF with a sperm from one of the men, or the other is gestational surrogate and a donor egg, who are two different individuals. In that scenario, it has to be an IVF because they are two different women. In HIV couple, and I think this is going to be the last case that I can discuss, in HIV, as long as the male partner has unprotected sex only during ovulation, is on heart, has less than 50 copies of viral load, and has no other STI, sperm wash will not have any added benefits, and they can have unprotected sex only at the time of ovulation to try for a pregnancy. If none of these criteria are met, or even if one of them is not met, then a sperm wash is to be offered. However, they have to be told that it's not absolutely protective. The other option, of course, to reduce mother-to-child transmission or couple transmission is to offer a donor IUI. If there is HIV in the female partner, again, the female partner has to be on HEART and should have less than 50 copies of viral load before a pregnancy. And these individuals should have annual cervical screening as a rule. If both the individuals have HIV, then think about the welfare of the child. It has to be a multidisciplinary approach in that case. Screening for other sexually transmitted infections, vaccination against hepatitis B, ensuring that the hepatitis C is checked are all the mandatory requirements before treating such individuals, and thorough counseling and pregnancy implications have to be discussed with the couple when both of them are HIV positive and embarking upon the parenthood journey. I think I will come to these in my next talk on Sunday. It was lovely talking to all of you, and we will continue this on Sunday at the same time.
Thank you very much,